This week we're going to be examining health and healthcare and focus on the effect of race. These are our objectives for this week. We're going to describe the contemporary inequality in health and healthcare. Then, as usual, we'll examine various stock stories about inequality in health and medicine and apply the matrix lens to really understand the link between race and health. Although we were often told with COVID that we were all in this together, our COVID memories will vary because everyone was not affected equally by COVID. Vulnerable populations were disproportionately affected. They had higher morbidity rates and higher mortality rates. Therefore, it's important to understand the patterns of inequality in health and healthcare. COVID highlighted these inequalities, but these inequalities existed long before COVID. If we examine healthcare, we can see disparities in access to healthcare, quality of healthcare, healthcare received safely, and so on, depending on social determinants of an individual. The various reports which have been done, among them the National Healthcare Disparities Report, found that various groups of color, such as African Americans, Latinos, Asian Americans, Native Americans, and Alaskan Native, they all receive worse healthcare than whites. If we examine traditional healthcare or traditional health perspectives, which are often found in these various ethnic groups, we can see that traditional medicine, which was often used, acknowledged the relationship between people and nature and focused on the healing of a person and not just the illness. What we have found is that these patterns of inequality have long existed in healthcare and medicine. Medicine has a history of discrimination. Medicine was not well organized until the 1800s. Before that, really anybody could apprentice and say that they were a physician. It wasn't until the mid-1800s that the American Medical Association was developed, and they did this in order to disempower competitions such as traditional healers. And by the early 1900s, what we have found was that what we consider today professional medicine really dominated the field of healthcare. However, in order to practice medicine by the early 1900s, individuals had to belong to the American Medical Association, as they were the only legitimate practitioners of medicine that were recognized. However, Black physicians were originally excluded from AMA, and therefore they developed their own organization, National Medical Association. But most Black physicians were not allowed to practice in white hospitals. And although we have seen this inequality reduced, what we do find is that the legacy continues. Although the majority of entrants are no longer white men, we do find that those individuals who enter medical school, who matriculate, are now more likely to be women, but nonetheless white women. Fewer white men are applying, but we still see severe underrepresentation of people of color such as Latinos, Native Americans, African Americans in medical school and becoming physicians. In the 1800s, the perspective of social Darwinism was extremely popular. The belief that through evolution, the fittest had survived, and that society should be organized in a way to strengthen survival of the fittest and to eliminate those individuals who were seen as unfit. Therefore, the social construction of fit and unfit developed, and we saw the development of eugenics. This was the argument that natural selection should be hastened by policies that encourage reproduction of the fit, and those tended to be the upper class or Northern Europeans, and to sterilize those who were deemed to be unfit. As a result, we did see a large percentage of women, particularly women of color, who were sterilized. We also saw laws that really limited the space that people that were viewed as unfit could occupy, and immigration laws often reflected this by not allowing entrance to those individuals they believed were unfit. By the middle of the first third of the 20th century, 33 states had legalized eugenic sterilizations in order to decrease certain genetic traits. We find that in New Mexico, at any rate, Native Americans were sterilized in larger numbers than would be expected. And these sterilizations often occurred in hospitals here in Albuquerque, at Indian Health Services, or sometimes the University of New Mexico. Conversion therapy was also something that was popular. The idea that individuals who were LGBTQ plus were unfit, and that therefore physicians should try to locate any bodily defect that these individuals may have in order to decrease the number of individuals who were homosexuals. And there was widespread discrimination in their ability to receive health care. Conversion therapy, of course, was very popular, and this was the idea that individuals who had homosexual tendencies could easily be converted with the right treatment to, quote, healthy heterosexuals, unquote. We begin to see medical sociology develop more so at the beginning of the 20th century. And the focus of medical sociology was to analyze the social effects of the field and the practice of medicine. Conflict theorists argued that it was profit that motivated what was defined as a disease and who was treated. And certainly if we look at healthcare delivery today, we find that this theory can easily be supported. Healthcare is an institution that has been deeply enmeshed in other institutions. In other words, the inequities that exist in other institutions are reflected in the inequities in healthcare. So the question we need to ask then is, how does the institution of medicine reinforce inequality? And how is the provision of healthcare shaped by the intersections of race, class, gender, sexuality, and ability? The stock stories that we see about health often portray health as an individual matter. Individuals who have poor health are seen as having poor health because of bad choices they have made in terms of diet, in terms of exercise, in terms of environment in which they exist, in terms of, let's say, health habits that they engage in. But often it is not realized that there are external forces that are not easily controlled by those individuals who lack power. If we take the case of obesity, for instance, the common discourse around this is that individuals who are obese or overweight are so because they've made bad choices about their diet, bad choices about exercising, and so on. But in fact, we really need to understand, particularly with obesity, that the ability to make choice is very much influenced by an individual's life chance. In other words, the social class which you occupy and provides you with access to resources determines whether or not you can make healthy choices. If we examine the relationship between class and health, as was done in the video Unnatural Causes in Sickness and Wealth, students could see that there was very clearly a relationship between race, class, and health. The video clearly demonstrates not only that individuals in lower income strata have higher rates of various morbidities, everything from heart disease to diabetes, but that they also have higher rates of mortality and have lower life expectancy. And again, this video focused on social class, but as we've discussed numerous times, social class intersects with race. Those individuals who belong to ethnic groups, particularly minority groups, are more likely to live in poverty or to occupy the lower strata of social class. Despite the fact that the United States spends far more in healthcare than any other country, this is 2015, but we still far outspend others, we have some of the worst healthcare and some of the worst health statistics. If we look at two measures of the well-being of a society, we are aware of the fact that we fall far behind other developed countries. For example, we have a much shorter life expectancy than many developed countries in Europe, and we have a higher infant mortality rate than also those developed countries in Europe. So the question often is why? Studies have found that race plays a big part in this, and the stress that individuals who are members of a particular racial group experience really increases their risk to disease and to death. So what we have seen since the 1980s is that this racial health gap has significantly increased. It is interesting, though, however, to examine the epidemiological paradox, where Latinos who have similar social class standing to African Americans actually have better health outcomes. So this is one of the, paradoxes that you might consider. Despite similarities in social class, why do Latinos have better health indicators than African Americans? But it is important to recognize that there's considerable diversity in these so-called racial groups, whether it happens to be Latinos, African Americans, Asian Americans. There are various ethnic groups within each of these so-called races, and there's considerable diversity in the culture and in their access to resources. Therefore, that really needs to be taken into consideration when we examine differences across a particular racial group. And it is important to understand, as I've been noting, the complexity of intersectionality. Individuals do not simply occupy one social determinant. They occupy social class, which intersects with race, which intersects with gender, which intersects with sexuality, and which intersects with ability. Therefore, what we tend to see is that those individuals who are disadvantaged in various of these determinants of social health often have cumulative disadvantage in many areas, and this includes health. There is a legacy of mistrust among ethnic groups. If we examine how African Americans have been treated by the institution of health, we can very clearly understand why there is a distrust. In the 1700s, 1800s, drapetomania, which was running away to escape slavery, was seen as a mental illness, and individuals who were apprehended had their toes amputated so that they could not escape as freely. And of course, there's a legacy of Tuskegee, where a group of 400 African Americans were denied treatment because the Public Health Institute wanted to see how this disease progressed, syphilis progressed. And it was an experiment that many of you probably are aware continued for 40 years or 4 decades. It was an experiment that was only supposed to last a year, but because of the voices in public health, it continued for 4 decades. It's also important to realize that social determinants of health affect where individuals live, and an individual's race, their ethnicity, their social class will often affect whether or not they can live in healthy environments. Those individuals who are disadvantaged in various social determinants of health often live in sites that place their health at risk and increase their risk to early death. So epidemiology really examines the distribution of health issues by these determinants in a population. The Human Genome Project was started in order to see if we could really map human genes, and with respect to health, it was really about finding out if there were any genetic variations that might increase someone's risk to a particular disease. What we found, however, was that 85% of genetic variation is located in so-called races. And there's probably more differences. There's probably more similarities from one race to another than the differences that exist within a race. One of the things about the Genome Project is that it's important to recognize that although we may be able to find certain genes that predispose a particular ethnic group to a disease, it is important to recognize that the larger issue is inequality to resources, and this includes healthcare, that really affect someone's risk to disease or someone's ability to maintain healthy. The Indian Health Services was developed to recognize and deliver healthcare to individuals that are Native American. However, what we see is that the resources for Indian Health Services are often limited, and we tend to find that individuals who receive care in Indian Health Care Services often do not receive the best quality care because of the lack of these resources. And this is certainly reflected in shorter life expectancies as well as suicide rates. In the early 1900s, Margaret Sanger opened the first birth control clinic, which was set to give control to women over their bodies. But in fact, what it did was it limited births in immigrant families. It was felt that decreasing births in immigrant families would improve the stock of Americans. So it was really a racist type of policy. The second wave of inequality in healthcare, particularly with respect to gender, is about increasing reproductive and sexual health control. In the 1960s, we began to see birth control methods being more easily accessible to women. And then by the 1990s, Black women organized to discuss the inequities that existed in healthcare to Black women. And this became very evident, particularly when we looked at infant mortality among Black infants and maternal mortality among Black women, which is much higher than among any other group. And of course, the latest stage of reproductive rights is about the right to control a person's body, a woman's body, by having legal access to abortion. And we have seen that this fight for reproductive justice continues, particularly since Roe v. Wade was overturned by the Supreme Court a year ago. As a result, many states have restricted abortion access, and it makes it more difficult for women in these states to actually receive a safe legal abortion, without traveling to other states. And of course, many of these women are just unable to travel to other states because it is often poor women who are most affected by the restriction to abortion access. And finally, we conclude this unit by noting that there is a path to the future that would reduce health inequities, and that is by recognizing that they exist and that this isn't normal, that this isn't natural. We need to develop broad policies that can reduce these healthcare gaps, particularly among various ethnic groups and among people from low-income strata. It is important that medicine recognize this, and one way to do this is to begin to approach healthcare from an interdisciplinary and intersectional approach, because that provides us with a better understanding of the factors that affect an individual's health, their ability to maintain a healthy body, and the factors which increase individuals' risk to disease and early death. All right, the questions this week will have students further explore these issues.